Hello class and welcome to the channel Clinically Speaking. This is part 2 of the video series on pulmonary embolism. Part 1 where I have focused on the diagnosis is given in the description box below. So a patient with pulmonary embolism will mostly present to you with complaint of either shortness of breath and there would be on examination hypoxia and decreased blood pressure. So once the diagnosis is made, we have to first ensure that patient has got a saturation of more than 92%, and if the blood pressure is on the lower side, we have to give IV fluids, so somewhere around a bolus of 250 to 500 ml. So when the patient presents with low blood pressure and we give IV fluids, this increases the right ventricular filling and the right ventricular outflow increases. This leads to increase in blood pressure. So, whenever you come across a patient with hypotension and pulmonary embolism, the first step is to give IV fluid bolus rather than directly going on vasopressors. But if the shock is not responsive to IV fluids, you should not overload the patient with fluids. Why? Let's see. Because there is right ventricular strain and the right ventricle is not able to pump the extra volume out, more of the fluid is retained in the right ventricle and this increases the right ventricular strain and right ventricular ischemia. So you should only give somewhere around 500 ml of fluids, and if the shock is not responsive, you should start with vasopressors rather than overloading the patient with fluids, which can be counterproductive in this case. Once you have secured the vitals, the next step is to move on to assess the risk of mortality due to pulmonary embolism, because that is the main driving factor that helps us decide the further treatment. And how do we do that? We have to see something called as pulmonary embolism severity index. But this is a long list of factors and it's difficult to carry this out in emergency. So a simplified PACE score has been validated, which can be used to assess the risk. Apart from that, we have to see, is there any evidence of RV dysfunction? We will see how to assess RV dysfunction, and we have to look at the blood pressure. So these are the three most important things that help you decide the further treatment in pulmonary embolism. So I think the scoring is pretty simple to remember, in the sense that when you examine the patient, you have three factors in your hand. You see the heart rate, the blood pressure and saturation, and abnormalities in this could point to increased risk. Apart from that, age more than 80 years, history of cancer and any coexisting pulmonary cardiopulmonary disease. So any of the following risk factors if present, that means the patient is at higher risk of mortality due to pulmonary embolism. The next step is to look for any evidence of RV dysfunction, and there are three ways of doing it. First is echocardiography. Now, echocardiography is something that you can do bedside and is very important if your patient is clinically unstable. What to look for in echocardiography? So if the RV size, right ventricular size, is more than 3 centimeter, or if RV is greater than, the right ventricle is greater than the left ventricle, or if there is a McConnell sign. So this is an important MCQ. A hypokinetic mid right ventricular wall but a normally contracting apex. This is called as McConnell's sign. You can also assess the RV systolic function by something called as TAPSE, and normally it should be more than 1.7. If you find that the value is given less than 1.7, again it suggests RV systolic dysfunction. You can also see for the tricuspid annular velocity and pulmonary acceleration time, or pulmonary artery systolic pressure if greater than 30. So usually after you receive an echo report of your patient, you will have RV systolic function mentioned, you will have whether the RV wall is hypokinetic, you will have information about the RV ratio and pulmonary artery systolic pressure. These are the few parameters which are routinely recorded in an echocardiographic report. Now if you have got CT pulmonary angiography done, there are some signs that you can pick it up on CTPA imaging itself that can suggest you RV dysfunction or RV strain. So again, we will look if RV is more than LV. We will see if the pulmonary artery is greater than the aorta. We will see if the septa, the interventricular septum, is deviated towards right ventricle, or we will see if the IVC is dilated and if there is reflux of contrast into the IVC. If these signs are present, that's on CTPA, that suggests that the patient is having increased right ventricular pressure. Third is by blood investigation, that is to order cardiac biomarkers. So we will order for troponin I and either BNP or NT-proBNP, whatever is available in your hospital. So now let's look at the signs that we already discussed could be there on your CTPA imaging itself. So here this is the aorta and the corresponding section of the pulmonary artery is larger than the aorta. So this suggests that there is pulmonary arterial hypertension. Also, a PA diameter of more than 3 cm is classical for PAH. Apart from that, here we can see that the RV is greater than the LV and the septum is curved or deviated towards the left ventricle. So if you pick up these signs on CTPA, you can have an estimate that there could be right ventricular strain, and that you have to confirm with echocardiography and blood investigation. So CTPA cannot replace your echocardiography, but it can give you a clue. So with this, we are going to move forward to risk stratification, and then we will learn how this guides our therapy. Now coming to risk stratification. So you will classify your patient at high risk of mortality if the blood pressure is low. So it's very simple. If the blood pressure is low, the patient is directly classified as high risk of mortality if the shock is not responsive to 500 ml of IV fluids. In such case, your PACE will obviously be more than 1 because low blood pressure is one of the criteria of PACE. Apart from that, there would be evidence of RV dysfunction on both imaging and in cardiac markers as well. Coming to low risk. In low risk, the patient will neither have low BP, the SPACE score will be 0, and there will be neither RV dysfunction on imaging and a normal cardiac troponin levels. So the patient is going to have pulmonary embolism, but none of the risk factors, a normal SPACE score, a normal RV function. Now coming to intermediate category. In the intermediate category of mortality risk, there are two subdivisions, intermediate high and intermediate low. So obviously here the blood pressure is going to be normal. However, the SPACE score will be more than 1. Now if the patient has evidence of RV dysfunction in the form of either imaging findings on 2D echo or CTPA and elevated cardiac troponin levels, if both the criteria are positive, the patient is intermediate high risk category. On the other hand, if the SPACE score is elevated, however only 1 or none is positive, then the patient is intermediate low risk category. Remember, both should not be present. So the patient might have evidence of RV dysfunction on echo, but the cardiac troponin level should be normal, or vice versa. In that case, the patient is classified as intermediate low risk category. Now coming to management of low risk PE. So the SPACE is 0, there is no shock, no RV dysfunction, cardiac markers are normal. In this case, you only need to do anticoagulation provided the bleeding risk is normal. So we will see how to assess for bleeding risk in a patient before starting anticoagulation in the further slide. But for right now, remember, low risk PE only requires anticoagulation provided the bleeding risk is normal. If the bleeding risk is elevated, then you need to put an IVC filter. So what is IVC filter going to do? IVC filter is going to prevent the further migration of clots from the deep venous system in the lower limbs towards the right side of the heart. So it will prevent further thromboembolism. So that's the role of IVC filter. Now let's move on to management of intermediate risk PE. So patients who are classified as intermediate low risk are managed just like low risk PE, that is with only anticoagulation, or if the bleeding risk is higher, with an IVC filter. There is no role of thrombolysis. Whereas in patients classified as intermediate high risk, observation is very important. If there are signs of worsening hypotension, respiratory distress, hypoxemia, tachycardia, syncope, elevated lactate, these patients may need reperfusion therapy. What are the reperfusion therapies available that we will see in the next slide? So, there are a subset of patients in the intermediate high risk group who are going to benefit from the reperfusion therapy, and that's why this category is so important. Now, what is classified as high risk PE we have already seen. So, unresponsive shock, a systolic blood pressure of less than 90 or systolic blood pressure of 90 on vasopressors or inotropes, or a drop in systolic blood pressure by more than 40 mmHg from baseline, which is persistent for more than 15 minutes. So if the patient has presented with a blood pressure of 140 by 80, but after 1 hour you find that the BP is 100 by 80. So now if you just look at the absolute value, the blood pressure is normal. However, if you compare from the baseline value, the patient classifies as high risk because the blood pressure has decreased by 40 mmHg from the presentation. Or if the patient has directly came to you with cardiac arrest, syncope. Plus, it's important to see if there is no other cause of hypotension which is treatable. So a patient which fits in this criteria is classified as high risk. These patients are directly eligible for thrombolysis followed by anticoagulation. Now coming to thrombolysis in these patients, again we have to assess the bleeding risk. In this subset of patient, we are going to use tissue plasminogen activator. The most commonly one used here is alteplase, and the dose is 100 mg over 2 hours. However, if the patient has presented with cardiac arrest or severe shock, we can also give 50 mg as bolus followed by 50 mg over 2 hours. There is another subset of patient in which thrombolysis is contraindicated or the risk of bleeding is high. So what option do we have for such patients? We can go for catheter based intervention. So what is a catheter based intervention? Basically you can enter the right ventricle through a peripheral vein, go inside the pulmonary artery and suck out the embolus. So that is suction embolectomy. Or through the same catheter you can inject the thrombolytic agent locally to disrupt the clot. So suction embolectomy is better than catheter thrombolysis, but these two are alternatives for patient who requires thrombolysis but is at high risk for bleeding. Assessment of bleeding risk. So there are various scorings for it available. The most famous one is Hasbled score and VT bleed score. There are some overlapping points in any of the scoring, and that is any bleeding within the previous 3 months, any kidney or liver dysfunction, older age, or presence of active cancer. These are the general factors which are included in most of the scoring. So if we see in the Hasbled, uncontrolled blood pressure, again abnormal renal or liver function, any history of stroke, bleeding predisposition, labile INR, patient taking warfarin, already taking NSAIDs or aspirin, elderly patient more than 65 years of age. So you can easily calculate the scores. The calculators are available online. But you have to in general remember these are the factors which increase the risk of bleeding. Now in the further slides we will just be summarizing everything that we have learned till now, and then we will apply it to a case. So this is the management of hemodynamically stable pulmonary embolism. Does the patient have any biochemical or radiographic evidence of RV dysfunction? If neither is present, no shock, hemodynamically stable, no RV dysfunction, the patient is low risk, and as we have seen, we have to decide the bleeding risk. If the patient is not at higher risk of bleeding, we go for anticoagulation therapy. If the patient is at higher risk of bleeding, we place an inferior vena cava filter. If any of the two is present, either biochemical or radiographic evidence of RV dysfunction, the patient is classified as intermediate risk pulmonary embolism. If both the factors are present, then the patient is intermediate high risk category. If one of the two is present, either biochemical or radiographic, the patient is classified as intermediate low risk criteria. So patients with intermediate high risk PE who show signs of worsening like persistent tachycardia, syncope, elevated lactate, decreasing oxygen saturation or worsening oxygenation or respiratory distress, such patient might be taken up for reperfusion therapy. For that we have to first see the bleeding risk. If the bleeding risk is normal, then the patient can be taken for catheter directed extraction plus anticoagulation. However, if the bleeding risk is high, then only catheter directed extraction is indicated in such patients. In a patient who is hemodynamically unstable, we have to again see if the bleeding risk is high. If the bleeding risk is normal, the patient can be taken up for thrombolytic therapy, as we saw 100 mg of altiplase. In situations of emergency, we can give 50 mg bolus followed by 50 mg infusion over 2 hours. However, if the bleeding risk is high, then the patient can undergo catheter directed embolectomy or a catheter directed thrombolysis followed by placement of an IVC filter, because we cannot give patient anticoagulation. So these are the various catheter based therapies are available. Basically you can inject the thrombolytic agent locally, that is local thrombolysis, or you can do the ultrasound guided lysis. You can also aspirate the clot, or you can do a mechanical thrombectomy. These are the options available for catheter based treatment. So now time to apply everything that we have learnt with a case management. So he is a 65-year-old male who has presented with sudden onset dyspnea, palpitations, room air saturation 85%, heart rate of 120, BP is normal, non-smoker, no other comorbid illness, underwent a CTPA and was found to have pulmonary embolism. Now how are you going to manage the patient? The first thing, stabilize the vitals. So start him on oxygen. The blood pressure is normal, so IV fluids are not required. Patient was started on nasal prongs 2 liters and he was maintaining saturation more than 92%. After vitals, the second step is risk stratification. So first we will see the SPACE scoring. So the room air saturation is less than 90 and BP is normal. Heart rate is more than 110. So the scoring is at least more than 2. The scoring is at least more than or equal to 2. The third step after that is to look for cardiac dysfunction. So we send the cardiac markers, troponin and BMP, both are elevated, and we did the echocardiography, and here we saw RV systolic dysfunction is present, RA-RV is dilated and pulmonary artery pressure is more than 30 mmHg. So we have both cardiac markers elevated as well as imaging evidence of RV dysfunction. So this classifies our patient as intermediate high risk. So we know what is the diagnosis, what is the risk stratification, what is the bleeding risk. So because my patient does not have any history of cancer, kidney disease, liver disease, any history of active bleeding, stroke, or any history of taking NSAIDs, aspirin or anticoagulants, my patient was at a low risk of bleeding. So we started him on anticoagulation and kept a close watch. In case my patient would have deteriorated, then the patient could have been taken up for reperfusion therapy, that is catheter based thrombolysis and followed by anticoagulation. So with this I come to an end of our discussion on management of pulmonary embolism. Share it with your friends and colleagues who can benefit from this lecture. See you in another video with another clinically interesting topic. Thank you so much.